Thank you, Arif, for this very kind introduction. Again, it's amazing to see so many people here physically, but also online attending this morning the Rare Disease Conference. Thank you, Dr. Amen, and the organizers for inviting me for the talk. I'm going to talk to you in the next 25 minutes about approach to white matter disorders in children and recent advances in therapy. And for the purposes of the talk, I'm going to refer to white matter disorders being inherited metabolic white matter disorders. So I'm not going to talk about autoimmune or infective or toxic white matter disorders. So I'm going to give you a little introduction to white matter disorders, inherited white matter disorders, clinical features common to leukodystrophies, the imaging approach, because imaging has really become an important facet of identifying this myriad of complicated disorders which present with very similar clinical phenotype. The clinical clues which lead you to assessment and investigations. And of course, most importantly, what we all work for is therapy. What's happening in the field of therapy. For a very long time, these conditions were untreatable. Now there is a lot of movement towards emerging therapies, which is very exciting. So very briefly, leukodystrophies versus genetic leukoencephalopathies. So what do you mean by leukodystrophies? These are heritable disorders affecting the white matter in the brain. And we know white matter is essentially the axons, therefore carrying the cellular information from the motor cell. And in the central nervous system, this can be affected in leukodystrophies. But in addition, because axons are not just present in central nervous system, they're also present in peripheral nervous system, they can be affected in these conditions. The genetic leukoencephalopathies, on the other hand, are really a secondary effect on the white matter from primary either vascular or neuronal or systemic diseases. So they are quite different. They are secondary phenomenology. So we're going to primarily concentrate on the leukodystrophies here for the purposes of the talk today. Are there certain clinical features which are consistent with leukodystrophy? Of course, this is a condition which affects all age groups, so it can present in childhood, can present in teenagers or adults. And the onset of symptoms can be variable at any age group. The key important thing, unlike vascular or inflammatory leukodystrophies, is this is a chronically progressive condition. Once it starts, it sets in, is chronically progressive, and there are no relapses. So there is no setback to baseline. Often in other leukodystrophies, you see condition emerging, coming back to baseline, emerging by baseline. But in inherited leukodystrophies, there's a constant decline and no return to baseline. You can see that white matter consists primarily of axons, so the cell and the transmitting fibers. So any condition which affects the axons will affect motor fibers, therefore motor function, motor tone, as well as motor coordination. And that is where the predominant findings are. So you'll see progressive paraparesis, ataxia because of effects of the white matter within the cerebellum, and of course, any coordination of motor system. In addition, you get tone problems like dystonia, seizures, and of course, psychiatric disorders. There are some extra neurological features which are also present in this context in certain diseases. So you have adrenal leukodystrophy, where the adrenal insufficiency may be present, or xanthomas, which is accumulation of xanthomatous tissues in cerebrotendinous xanthomatosis. The inheritance is very variable. It could be autosomal dominant or recessive or even X-linked. It's a good slide to pay attention to. So as I said to you, neurological signs and symptoms which are pathognomic are quite common. And you can see the gait problems, spasticity, cognitive impairment, ataxia, and dystonia as your primary lead-in to any of these conditions. So when you have these motor systems predominating, you know you're dealing with a white matter disorder. The clinical aspects, of course, depend on the age of onset and the extra features you see outside of the nervous system. And the mode of inheritance may be a common lead-in. So if you've got a family history, it helps you determine the condition as well. Investigation-wise, brain mapping, because white matter is so accessible to brain mapping in terms of MRI scan, that really helps you. And I'll take you through how we go about looking at MRI scans, thinking about various white matter disorders. In addition, the tests, which are ancillary tests like nerve conduction or motor sensory evoked potential, help you determine the extent of the disease, whether it's limited to the central nervous system or it is also affecting the peripheral nervous system. And then finally, diagnostic confirmation, and that's where a lot of recent advances have been leading to further therapies. So just to give some clarification of how white matter changes appear in the brain, you can either have demyelination, that means you have the axons where the myelin's been stripped or lost because of inflammatory disorders or toxic disorders or infections. And that's usually multifocal, but asymmetric. And that's the key. While the inherited disorders, which are dysmyelination, that means the myelin is abnormal because of either lack of enzymes or accumulation of abnormal substances, that's confluent and symmetrical. Big, clear determination. So we have a very clear three-step approach in MRI scan. We are looking for symmetrical white matter disorders, and that's an essential finding. The type of sequencing you have to insist on is T2-weighted and flare imaging. And often, sometimes when MRIs are done, if the radiographers are not paying attention, they will miss out flare sequences. But increasingly in centers where multi-specialties are there and the pediatric multi-specialties are there, these sequences are included within the pediatric MRI scans. Periventricular pattern is the most relevant pattern. That means white matter around the ventricles. And MR spectroscopy, this is a hidden gem. This is often not added on, but you need to speak to your radiology department that when they see a leukodystrophy, they need to do MR spectroscopy because it helps us identify the chemicals within the abnormal chemicals within the white matter. And also it can be used as a non-invasive biomarker for treatment when treatment is started. So what do you do? First step, you identify symmetrical white matter involvement. Particular sequencing I've just told you, but the white matter abnormalities must spare the U fibers, the fibers which are very close to the cerebral cortex. If it is involving this U fibers, we are dealing with something different. Second most important is looking at the patterns of white matter involvement. Different patterns signify different disease. So whether the white matter abnormalities parieto-occipital, which is posterior, or frontal, or periventricular, or subcortical, or brainstem involvement is there, or cerebellar involvement is there, that gives us lead into that. I'm not going to elaborate multiple diseases. It just tells you pattern recognition is really important. And then you recognize distinctive features within the pattern, like the presence of cysts, like the presence of calcifications and microhemorrhages, like the presence of enhancement of the abnormal white matter, like the presence of certain chemicals within the white matter in MR spectroscopy, and the presence of spinal cord. So all this is becoming a confluent leader into how you're going to think about where your investigations are going to focus. Once the MRI scans suggest abnormal myelination, and you made sure that you excluded inflammatory, infective, and toxic causes, you have a very predetermined list of investigations. Biochemical investigations, which include the serum amino acids, lactates, lysosomal enzymes, cytosine, very long-chain fatty acid, cholesterol, organic acids, urine sulfide, urine sialic acid, and CSF studies in the last step. Moreover, nowadays, because of neonatal screening, we are picking up a lot of organic acid disorders, which will lead into early diagnosis. Genetic testing, if you are very clever, you can pick up the single gene disorders and test very quickly. The difference is when you know what single gene you're dealing with, the turnaround time is very fast, maybe 2 weeks or 3 weeks. It's more likely than not, if you don't have a diagnostic clue, that you're going to have to go to next generation sequencing, which is either whole exome sequencing or now whole genome sequencing. Now that takes about 4 to 6 to 8 weeks to return. Once you've done these tests, we also do some ancillary tests, which is essentially trying to tap whether the white matter disorders are going to affect the peripheral nervous system. You can do nerve conduction study, evoked potentials, EEGs, developmental screening, etc. That's a very nice demonstration of pattern recognition. The MRI scan, predominance. If you see a frontal predominance, we're dealing with Alexander disease. If you see a parieto-occipital predominance, we're dealing with adrenal leukodystrophy. If you see subcortical involvement, we're dealing with Karen-Sayers or mitochondrial disease. If you're dealing with periventricular patterns, which is D and E, we're dealing with metachromatic leukodystrophy. If you're dealing with diffuse pattern, that's Batten's disease or neuroceroid lipofuscinosis, and then other patterns of cerebellar involvement, which will present in cerebrotendinous xanthomatosis. Some other ancillary tests, as I said, the evoked potentials, you can do eye examination, skin biopsy, urine analysis, and this will all lead us to understand which other systems are involved, which other end organs might be involved in this process. A very brief review of few important white matter disorders. Metachromatic leukodystrophy. This is an autosomal recessive dystrophy, which shows progressive myelination of the CNS as well as the peripheral nervous system. And there is a mutation in the aryl sulfatase A gene, which leads to desulfation of cerebroside sulfate. This leads to an accumulation because of the blockage of cerebroside sulfate and leads to leukodystrophy. There are 3 major types. I'm going to just simplify it to late infantile onset or juvenile and adult onset. And the importance of late infantile and juvenile onset is they get very significant symptoms early on. Almost all of them present with motor skill problems, gait difficulties, tone problems, hypotonia, eye involvement with optic atrophy, and peripheral neuropathy. The adult disorder is slightly different, presents with predominant psychiatric dysfunction. The diagnosis can be easily achieved by enzyme testing in white cell enzymes. So it can be quite achieved. An MRI scan is, of course, very predominant in periventricular distribution of the white matter pathology. There's no real curative treatment, but bone marrow transplant has been well established as therapy, and nowadays gene therapy, and I'll talk about that in a bit later. The next important disorder, of course, this is a familial disorder, which is an X-linked adrenoleukodystrophy or adrenomyeloneuropathy. This is a paroxysmal disorder of beta oxidation energy production and leads to accumulation of very long chain fatty acids in all tissues because of lack of progression in the beta oxidation chain. The mutation is in the ABCD1 gene. Again, there are 3 phenotypes, and you can see that universally in any leukodystrophies, there are the childhood, the juvenile, and the adult forms. In X-linked leukodystrophy, it is very peculiar that the childhood form presents primarily cerebrally, and you get learning difficulties, cognitive behavioral difficulties, blindness, and quadriparesis. And then this older form presents with a predominant motor disorder. This is between 20 to 40 years with paraparesis, sphincter control, neurogenic bladder, sexual dysfunction, polyneuropathy, cerebellar disorder. And 30 to 40% have about adrenal dysfunction. Then there's a very rare form of adrenal insufficiency, which doesn't present with cerebral findings. And that is the only sign in these patients of adrenal leukodystrophy. Majority of them present before the age of 10 years, but can be present at any age and then go on to develop myeloneuropathy later on. So again, allogeneic hematopoietic stem cell transplantation and gene therapy is becoming the therapy of choice in these conditions. Another rare condition, Alexander disease, which is really a disease which carries high mortality and morbidity in youngsters. And that's due to diffuse Rosenthal fibers accumulation in the cytoplasm. It's autosomal dominant, and the genetic defect is in the GFAP gene. It affects majority infants and young children. The adult form is rare. So you can get the neonatal form, the infantile form, the juvenile form, and rarely the adult form. And the key feature of the younger presentation is the large head. They tend to get features of raised pressure, seizures, motor retardation, and etc. So that's a much more severe degenerative disorder than any of the other leukodystrophies. The juvenile form is normocephalic. They have normal head circumference, while the infantile and the neonatal form have larger head. The adult form is variable. It presents with more bulbar dysfunction, dysarthria, dysphonia, then progressive motor signs and ataxia. The cognitive functions are normal. Another rare condition is Pelizaeus-Merzbacher disease, which is X-linked and leads to majority of presentation with eye signs, with nystagmus, also increasing spasticity, a movement disorder, which is acidosis, tremors, and ataxia. And you either have the conatal form, which is the early presentation, or the classical form. Both, except for the presentation in the in different stages, primarily involve motor fibers, eye signs, and a movement disorder. This is a very interesting disorder, crabal disorder, and very pathognomic, because these children present with extreme agitation. And this is quite unique in this condition. So if you see a young child under the age of 6 months presenting with extreme irritation, crabal disease should be on the top of your list. This is a condition due to deficiency of beta galactocerebrosidase and leads to apoptosis and gliosis and destruction of the brain matter. Under the age of 12 months, as I said, kids present with excessive crying, feeding difficulties, reflux, hypotonia, and spasticities. Hypotonia centrally, marked spasticity in the upper limbs. And it's a very great challenge. How do you deal with these kids? Because they are extremely irritable. The older kids show a slow loss of development, loss of milestones, slow speech, a motor disorder immersion, visual loss, etc., with seizures. Again, because of early presentation, this can be identified and we can do bone marrow transplant. Canavan's disease, another disease with a large head, is a spongiform destructive leukoencephalopathy. Leads to increased NA, which is N-acetyl acetate, metabolism abnormality, and leads to accumulation of NAA. They usually present between the age of 3 to 5 months, again with delay in development and progressive spasticity and a large head. Quite a few interesting disorders. This condition was described about 15 years ago called vanishing white matter disorder. This is again an inherited recessive disorder. And there's defective functioning of protein recycling. And the age of onset can be quite older, between the age of 2 to 5 years. And the peculiarity of this condition is once it sets in, it can be triggered by events like fever or a minor head injury or minor infection. And every time a child has some sort of intercurrent infection, the brain takes a hit again and they get leukodystrophy, which is destructive. And the key name of the disorder is because of the vanishing white matter. The white matter keeps being destroyed and eventually disappears and becomes multicystic leukoencephalopathy. One of the doyens of white matter disorder, Professor Vandenap, has her name to many of these conditions, has been very eloquent in describing white matter disorders. And she describes this condition where there is meganencephalic leukodystrophy, so children who present with large head, a white matter disorder, and very peculiar cystic presentation in the anterior temporal lobe. Not everywhere, just in the temporal lobe. And that's also due to a genetic defect in the hippocampus gene. Progressive disorder again. And then, of course, most importantly, as you heard in the last lecture, organic acidosis, which present mostly in the first year of life with developmental delay, intellectual disease problems, vomiting, failure to thrive, hypotonia, seizures, coma, respiratory distress, cardiac dysfunction. And are exemplified by metabolic acidosis, high ammonia. MRI scans will show diffuse white matter changes. And the analysis of organic acid, especially nowadays in the neonatal screening, will identify many of these conditions. We're going to skip that. Treatable leukodystrophies. Now coming to treatment. All of these conditions are really devastating with significant mortality and morbidity. Many of them have now some treatment available. Adrenal leukodystrophies, cerebrotendinous xanthomatosis, crabal, and metachromatic leukodystrophies. Once you identify them with a screening test, early bone marrow transplantation. Some of them have chemicals that you can use, but bone marrow transplantation being primarily. The trouble with bone marrow transplantation is there is high amount of risk involved in that, and the benefits and outcomes are not 100%. So the mortality and the morbidity associated with the treatment itself is quite high. So the focus in the last many years, or last 5 or 6, 7 years, has been to find a way of decreasing the morbidity and mortality of doing stem cell transplantation or bone marrow transplantation, and finding therapies which may be less problematic. And that's led to what's called gene therapy or gene modification therapy. Now, I'm going to skip very quickly because these are just repeat slides of conditions. The recent advances in the diagnosis and treatment has been, we are very quick nowadays at picking up. Many of these conditions are there in newborn screening. If they're not included in the newborn screening, when there's the emergence of symptoms, we are very quick at performing MRI scans, which leads to identification. And then more and more genetic testing has become much more accessible and available to us with turnaround times of maximum 8 weeks, even if we are doing whole genome sequencing. Once identified, these conditions, or are they pre-identified in the family, then they can be treated with early either hematopoietic stem cell transfusion or autologous stem cell transfusion. And with increasing expertise, we have ex vivo gene therapy with lentivirus or gene therapy itself, which is much more, which has gained much more ground. So lentivirus vectors are used in stem cell gene therapy, have now become FDA approved in metachromatic leukodystrophy at least. But there are many, many such treatments which are under under trials at the minute with advanced therapy trials. And the future of gene therapy in many of these conditions looks very promising. And many of them have preclinical studies and clinical studies which are ongoing. And in the next few years, we hope to see much more emerging varied gene treatment for these conditions, which are all going to be amazing because these conditions are horrendous, both in the morbidity and mortality. So there's a lot of profiling going on, a lot of treatment being thought about and being processed. So just concluding, white matter disorders due to inherited leukodystrophies are rare conditions. They are clinically challenging to diagnose, but if you follow the methodology, you can achieve diagnosis quite quickly. You need a structured approach with appropriate investigations and early diagnosis. MRI brain scans, enzyme analysis, gene testing, all has led to this very significant jump in early diagnosis. And that's really important because with early diagnosis comes early treatment. And we know that every day you lose nerve cells, you cannot regain nerve cells. And if you can intervene in a therapy, either pre-symptomatic or at early time of destruction, you can save the brain and prevent the mortality and morbidity associated with these conditions. Thank you.